Good evening, and how are you doing today? Welcome again to another session here on my page where we talk about health. My name is Dr. Frederick Unubahai, and I always tell you good life na sense. Now, today again, we'll be discussing about or talking about antenatal care, and I have a guest, a consultant, a specialist, and he has always been here to break some things down for us. So if you're a woman or a man and you want to know more about antenatal care, I think this platform is for you. So don't miss it. I want to bring up my guest tonight. I can see some people are already joining me right now. We are live on Facebook and we are live on YouTube. Let me bring up my guest. My guest is a consultant obstetrician and gynecologist. He works at the ERA Specialist Teaching Hospital. I always introduce him as my teacher while back in medical school, and it's an honor to have him on this page again. Let me bring up Dr. Joseph Okwegwale. Good evening, sir.
Thank you, Fred. Thank you, Fred. How have
I
you
am
been?
aware, very well,
I'm happy
sir.
to
I'm
be here
aware that
again.
you are very, very busy and you are still at work, sir.
Yeah, yes. A lot to do. A lot to do. Um,
Thank you so much, Chief. Thank you
yeah,
for
yeah,
joining
yeah,
us tonight.
yeah,
We
yeah.
have people
Good
already
to be
here.
here.
We have Joy. Joy is here. Helen is here. Leah is in the house. We have a lot of people joining us. Without wasting
Yeah.
time, Chief, this whole discussion about antenatal care, I know you would help us break it down what it means, but there's one question that has been on my mind for a very long time. And the question is, when should a woman start antenatal care? Let's start on this note and then you can take over, sir.
All right. Thank you very much, Fred. And I'm very happy to be here again. Like I told you, I've always enjoyed this program, and I'm very happy that I'm still part of your program. Yeah, antenatal care represents a pattern of care that is
Mm.
organized for women who are pregnant, a
Okay.
specialized pattern of care which is organized specifically for women who are pregnant to enable them to attain and also to maintain that state of good health throughout pregnancy, and also to increase their chances of giving birth to a healthy infant at term.
Mm.
You know, those are the words. It's a specialized form of care. It's not just a care that can be given by anybody. It's specialized form of care that is offered to just women who are pregnant, not other group of women, not women who are trying to get pregnant. These are women who are already pregnant. To enable them attain that good health that they desire. And not only attain that good health, to also enable them maintain that state of good health throughout the period of pregnancy, so that their chances of giving birth to a healthy infant will be increased. And that is it. Then you will want to ask, why should a pregnant woman want to have an antenatal care? Why? Why should a pregnant woman want to have further care when she is already pregnant? There are usually some reasons. There may be some pre-existing medical condition which that woman may not have been aware of, and which could negatively influence the progress of that pregnancy. So attending antenatal care will help to detect those pre-existing medical conditions so that they can be dealt with. That doesn't cause problem in that pregnancy. Outside that, it may also serve as a period where certain screening can be conducted for that woman to be able to detect some problems which ab initio the woman was actually not aware, that are there. Such problem may have developed in course of the pregnancy. But while screening this particular, pregnant woman, you're able to detect those problems and act on them early. Outside that, antenatal care will help to follow up both the pregnant woman and detect any complication in course of the pregnancy, as well as the baby this woman is carrying. So for both the mother and the baby, and of course, to prepare the couple. I don't just mean the woman now. I mean the couple, the husband and the wife, to have a successful childbirth. You don't just have an antenatal care because you want to have an antenatal care. It also gives room to the person seeing you to plan, to help you plan on how that baby the woman is carrying is going to be delivered. So the plan is for both the husband and then for the wife. And like you said, when is it advisable for a woman to actually book? Usually we advise that a woman should book after a second missed period. It's usually not so good to book very, very early. You are just missing your period now. You want to go to the hospital to go and register. No. You have to watch it and then you wait. So we say, okay, except the woman had existing medical conditions in the past, have had a previous ectopic gestation, have had severe medical condition that requires that woman to present very early. As soon as you miss your period, you have to quickly run down to the hospital. In the absence of any problem, it's usually advised that a woman book after a second missed period. And there are several models of antenatal care. The model we practice here is just the traditional model of antenatal care. Then in many developed climes, they practice the focused antenatal care. And there's another model called the WHO antenatal care. In each of these models of antenatal care, the first visit is usually after the second missed period. So they are just on the same page. So it's important because at that time of booking, that's actually the best time to perform the very first scan for that pregnant woman. It will enable you to date, what we call date, to know the exact pregnancy date, the gestational age of that pregnancy. That's basically the most important kind of scan to confirm the viability, to be sure that the baby the woman is carrying is viable, is okay. And then to be able to date, you must be able to know, okay, I know, to be sure that, give the woman the particular date, the number of weeks, how many weeks the woman is pregnant, and then you'll be able to talk to the woman about the pregnancy. So it's actually best to book after that second missed period. Okay, I can't hear you. Can you hear me? I can't hear you. Can you hear me? Okay, yes. I can hear you now.
Yeah.
Okay.
I did mute my mic right now. Okay. Thank you very much. Good evening, everybody. You are welcome. We're talking about antenatal care, and we have Dr. Joseph Okwegwale, a consultant obstetrician. He told us what antenatal is, told us antenatal care. So we are going forward because of time. We don't want to spend much time tonight. What are those things that a woman should know when she's going for antenatal care? Because I have heard ladies or some women who tell you that, why should I go for antenatal care? After all, I have given birth twice or 3 times. There is nothing else I need to know about antenatal care. So what should a woman really know and look out for when she goes for her antenatal care?
All right. Okay. Let me quickly mention this. Who can provide that guidance? Who can guide the woman through the antenatal care period? Is it just a doctor? Is it just the nurses? Is it just the midwife? That's another question that we need to ask ourselves. When the woman is pregnant, who is that woman expected to see? Because at one point in pregnancy, we advise that women try, at least meet some of these people who have these requisite skills, to carry them through the pregnancy. There's a term we usually call skilled bed attendant. A skilled bed attendant could be a doctor, it could be a nurse, it could be a midwife who have been trained to proficiency. He has been trained. The attendant has been trained to proficiency on how to recognize some of the complications that can endanger the life of the woman and that of the baby in course of the pregnancy, and refer promptly to the respective quarters where that woman can be properly managed. It may not necessarily be a doctor. That is why if you go to some, some villages, some communities, you may not find a single obstetrician. We understand that obstetricians are at the high, the habitat, the zenith, they are there, but you won't find obstetricians in many communities. So you can't wait for obstetricians to see all pregnant women alone. So there are a group of people who are specialized, who have that skill, who are able to recognize some of these dangers, and they are called the skilled birth attendant. They could be the nurse, they could be the midwife. That's why when you get to some primary health care center, you see a couple of midwives, you see a couple of nurses attending to many pregnant women. It's not a bad idea at all. So because particularly when they have been trained to proficiency and they're able to identify those problems. But the issue is this. The issue is this. You must be able to, and they must be able to identify and the limits to which the kind of pregnancy they can handle. And because that's what the training talks about. If a woman has had a background, that's the essence of people having a booking clinic. Now, when a woman presents the very first time for an antenatal care, the very first thing the skilled birth attendant does is to triage and try to classify the woman whether this is high risk or whether this woman is a low risk pregnant woman. And what do I mean by high risk pregnant woman? A woman that had a background medical condition. She's hypertensive, she's diabetic. She has had previous history of pregnancy losses. She has had several pregnancy losses in the past. She has had unexplained stillbirth. She has had early neonatal death. She has had an intrauterine fetal death. She has had previous surgery, previous cesarean sections done in previous pregnancies. Those are not the kind of patient that a particular midwife or a particular nurse should continue to see. But that very first visit, they should be able to see them and advise them that subsequent visit, or they can arrange for a visit. Between such institution, may just be a primary health care setting and a tertiary care setting where they will have access to an obstetrician. So you see the ability to identify those problems because they will come. I'll give another example. Women who are carrying the very first pregnancy may not necessarily be a very high-risk group of people, but it still remains a high-risk pregnancy because first pregnancy may be saddled with a lot of problems. I will mention just a few. Now, a woman who is pregnant for the first time is new to the pregnancy. So the chances of vomiting, nausea, that will result to more vomiting is there. And if it's not properly taken care of, it's possible that you continue to vomit, have electrolyte imbalance, and have what we call hyperemesis gravidarum. That's a complication that can occur very early. Now she's vomiting, she's not eating well, the risk of having nutritional anemia is there, and then she becomes dehydrated and all that. Those can occur early in pregnancy. And in moving from first trimester into second trimester, you see that they become more predisposed to having some medical conditions in pregnancy, pregnancy-induced hypertension, preeclampsia. And if you don't properly manage those hypertensive disorders in pregnancy, it could lead her to have eclampsia, which is seizure in pregnancy with attendant complication. Labor could be another challenge for women who are having, who are in their first pregnancy. Their pelvis is untested. Their labor can be unusually slow. And of course, the risk of having what we call slow progress, obstructed labor, is high. And if you don't detect that the labor is obstructed in time, it's possible to not have an injury complex, which have an immediate and long-term complication. They could have vesicovaginal fistula, they will continue to pee on their body, wet their body, and all. A couple of complications can occur during the labor of a woman who is carrying the first pregnancy. So it's important that there's a linkage between the primary care scene. If the woman is unable to access an obstetrician at the time is booking, he must be able to see somebody who is sensible enough to manage that pregnancy to such a point that at the point that complication is developing, the person has somebody that you immediately refer that woman to for subsequent care. So that's what happened. A couple of things can happen to a woman during pregnancy. Some of them are already mentioned. There may be some conditions the woman wasn't aware of before the pregnancy, and then now become evident in course of the pregnancy. And then the woman could develop medical disorders in pregnancy. Baby could have some problems. The mother could have some problems. These are the reasons why they must register. And they have to register so that some of these problems can be detected early and taken care of.
Thank you very much, sir. I want you to please help us share maybe one story of a case in which a woman did not register for antenatal and then she came to the hospital, maybe at the late stage or to put to bed. Because again, we hear women tell you that I'm experienced in pregnancy. Why should I go for antenatal? It's only when I'm in labor I will go to the hospital. I know you might have gotten experiences of such cases. What are the dangers that people should know about?
Okay. You see, there are two groups of women that you usually see. The ones that you see in antenatal care, who you have followed up, you've reviewed their investigation, and you've been able to classify whether they are high risk or whether they are low risk. They have been following you. Those are your book patients. There's a second group of patients of women who are unbooked. They are just coming to you probably because they had developed complication at some point in pregnancy, or they are just coming to you for the first time to come and register for that pregnancy. We usually have this group of people. And oftentimes when they come in, they present with a lot of challenges because the pregnancy has not been booked. You are not sure, of whether complications had happened in that pregnancy. So at that point, you're almost like starting all over for what you may have prevented if the woman had presented earlier. Now, there are a certain group of people who have delivered severally. Some are even delivered at home. Some group of people we call grand multiparous patients, they are there. They had delivered, some have had 4, 5, 6. So they will feel like coming to antenatal is really not necessary. After all, they have been giving birth, they've been giving birth at home. So why should I be coming for antenatal care? We see them most of the time. But you see, this group of people are actually very high risk. Why am I calling them high risk? Now, for them to have delivered 1, 2, 3, 4, 5, age may have not been on their side, and they may have developed medical conditions all along, for which many of them may not have had, probably many of them may also have been poor, so healthcare or health-seeking behavior may also have been poor. So those problems follow them through pregnancy. So right from the first trimester from which they are pregnant, through the second trimester, up till when they are in labor, the problems are there. But some of them may not be evident very early, until late in that pregnancy when they begin to come to you. For instance, in labor, the risk of bleeding is very high in those kind of women. What we call postpartum hemorrhage is high. Some may even have precipitate labor. Some are predisposed to having malpresentation, malposition, and abnormal lie, which could cause problem at the time of delivery. So the issues are usually more. So when they come in, you try to start some of those things you would have done for them earlier if they have presented earlier, like basic investigations, because you still have to check if you have that time, except they are coming in labor. Okay.
You mentioned malpresentation, abnormal lie. Could you help us break it down for those people who really don't know
Okay.
what it
What
means
I'm
to work?
saying is, when a woman is when pregnancy is progressing, it gets to a point at which you expect the fetal, the normal fetal presenting part, the part that should be facing the vaginal area. For women, you are expecting to have a vaginal birth, conduct a vaginal birth. For the head, should be facing the pelvis towards term. Term is actually what people call 9 months. It's 37 completed weeks to 42 weeks. You know, sometimes doctors count in weeks. A woman is usually expected to give birth at term between 37 completed weeks and 42 weeks. 9 months usually start to count from 36 weeks. But by 37, at least it's adjudged that the fetal lung is matured enough for that baby to come out. And the physiological process of labor begins to set in from that time, you know. So it's like a physiological clock. So from that 37 completed weeks, is expected to what? To deliver. That's what happened. At that point, over 98% of women will have the head of the baby facing down the pelvis. A very high number. But in some cases, you still find that either the buttocks is now facing down or is having an abnormal presentation, is having a transverse, lie, or instead of the head to be facing down, the buttocks is now presenting, is now facing down. That's what we call breech. That means the buttocks is down. Then you can have an abnormal lie. It's lying, the lie is also not a normal lie. So you have different type of malposition, malpresentation, which could predispose to, in which vaginal birth may not be indicated with those abnormalities. Such women, you may have to advise them to what? Either have a cesarean section or the other manipulations you could do, such that if they had presented earlier, you would have been able to help. But because they are coming at that time, they are unbooked, you are not too sure, of their obstetrics conditions, they may come in at the point that you quickly want to act because a problem is already there. So ending up in, if the woman has not developed complication, you may end up performing an emergency cesarean section for them. Even at that, the risk is still high. A woman who has delivered several is at risk of having low-lying placenta previa, morbidly adherent placenta, which could cause the woman to bleed more at the time of delivery. So if such a woman is trying to deliver, she may come into your labor ward, even bleeding. The baby may have been dead before the woman presents to you in labor ward. And if eventually you're able to evacuate the uterus, she starts to bleed, and you are left with no option than to just probably remove the uterus or other interventions, that will probably stop the bleeding, which will cause, has its own problems at the end of the day. So a couple of these happen to women who do not present early or who do not present to for antenatal care to register their pregnancy.
We have a question. We don't want to waste time tonight because our guest is very, very busy. He's at work. Um, in Nakaka says, but doctor, what about those that don't go to antenatal during the pregnancy period and still deliver at home like the Hausa people? What can be done to this kind of people? It's like it's a habit or it's like their culture. They don't see a need. So how can we pass this information to them, or what can be done in this regard?
A couple of people, not just, this thing is not limited to the Hausa tribe or
Yeah,
culture. It's
yeah.
something we see commonly in an environment that will see. Let me tell you, poverty is a major driver for a lot of obstetric problems. And you see, the health insurance scheme is poorly managed in such a way that even those, it's only the middle class and those who are rich that are benefiting from the health insurance that is supposed to go to these people who are living at very low life within this community. If you want to see real rural people, Get to communities and see what happens. I've conducted several projects in many communities. I've had projects conducted with traditional birth attendants and many other people, and you could see they give you stories of how people come in to deliver, what they do, the number of women who die. You know, they are eventually able to salvage some, but a couple of them die that you don't know. A couple of them actually die. Of course, there are many who have been able to, who have delivered before. The chances of having successful future deliveries are higher. But even because of that, the chances of bleeding and other complications that will follow, risk of infection that will eventually kill that woman, are also there. Many women in the communities are leaking urine everywhere, and they feel that that's just a normal. They've been meant to believe that those are some of the complications that could follow just a normal pregnancy when a woman delivers. Those could have been just complications that have been gotten from the pregnancy or the delivery, which was poorly conducted. So advocacy is still key. Unfortunately, we don't have so many doctors in the communities. I can tell you, if you go to rural communities, we have very few doctors. We're not even talking about obstetricians. They're not talking about obstetricians. We're not talking about nurses are leaving Nigeria in droves. They are leaving. People do not want to work in community, and that's where you are having the problems. See, in my hospital, I know a couple of people that have been brought in dead, as in brought to labor wards in the process of trying to deliver. You know, before they come in, they have bled and they have died. Hemorrhage still remains the commonest cause of maternal mortality in Nigeria. Nigeria still accounts for one of the highest maternal mortality rate worldwide. Nigeria and hemorrhage have been the leading cause, bleeding. And who are the people who are more predisposed to bleeding after birth? It's those who have given birth to higher numbers of babies. Those who have had complications that were not properly managed in course of the pregnancy, they are more likely to bleed. Women who are carrying pregnancy for the first time, the commonest cause of bleeding after birth is genital tract laceration. They may have vaginal injury, they may have vulvar injury, they may have injury to the cervix. And if you deliver with a skilled birth attendant, you understand that this is first pregnancy. And the risk of postpartum hemorrhage from uterine atony is very minimal. So the very first thing she does is to check the genital tract and be sure that there are no tears, because in the process of bringing out the baby, the cervix may be torn, the vagina may be torn, the vulva may be torn, and if the woman doesn't check very well, if the person taking the delivery doesn't check very well, the woman can continue to bleed. So for those who are delivering for the first time, genital tract inspection after delivery becomes very key for most of the skilled birth attendant. That's where the skill actually come in. Not just for people, not in a chemist place, not in a traditional birth attendant that haven't received that training on how to provide this adequate care for women who are pregnant.
Thank you, sir. We are about rounding up tonight. I want to ask maybe one or two questions. Now, a woman is pregnant. What should her lifestyle be like during the course of the pregnancy? What should her feeding look like?
Feeding, okay.
Yes.
Okay. Nutrition is an important aspect of pregnancy. To understand that during pregnancy, women are required to eat more. Women are required to consume calories of about 300 kilocalories more than what they were consuming before pregnancy. Because the hormonal influences are there. You have the baby to cater for. So there's an additional need to eat more. This is very important. There should be no particularly diet restriction in pregnancy, except there are indications to restrict diet. Carbohydrates, protein, those are important diets to be taken in pregnancy. But of particular note is that there are certain targets one has to meet in pregnancy. Now, at the very early stage of pregnancy, there are certain mineral elements or elements that are key, to pregnancy development. For instance, folic acid. So diets rich in folate are very important in early pregnancy. And you can get folic acid from vegetables and all that, green vegetables and many other things you can do. Outside all this, there are a few food one may say, okay, restrict all this in pregnancy. For instance, we don't advise women to take a lot of caffeine in early pregnancy because, caffeine has a couple of dangers when taken in high quantities in the period of development, particularly that very early stage of pregnancy, period of embryogenesis, gestational age still less than 8, when pregnancy is less than 2 months, And then outside this, taking normal diet, eating normal food, reduce fatty diet, reduce food that contains excessive fat is also advised. And then the kind of exercises that some of these women could have. We encourage regular exercises, but not those very strenuous kind of exercises that could put the baby at risk. Just normal walking, mild minimal exercises is fine. Those ones that will need you to do, those kind of press up, tummy top kind of exercise, football, basketball, that will put so much stress. Some of them, you can do so much exercise in pregnancy that will cause the placenta to separate from where it is. So those very strenuous exercises are not advisable in pregnancy. And of course, for those who have medical conditions like cardiac diseases, who are asthmatic, who have poorly controlled blood pressure, they are not even advised to do much exercise in pregnancy. Just walking around, maintaining good diet and all that are just enough to keep the pregnancy going. And then at the very early part of pregnancy, avoid taking so much medications. It's not necessary at the very early stage of pregnancy because medication can cause a lot of harm in early pregnancy. If you want to take paracetamol, you take in place of Panadol Extra. If you take Panadol Extra, you know that Panadol Extra probably contains some caffeine. You understand? You must check the component of anything you take that early period. What you need at very early stage of pregnancy is just folic acid. You take the folic acid and if you take the folic acid, that will just be it. Sufficient for that early stage of pregnancy.
Sir, we have a question from Rita.
Okay.
I don't know if you can respond. It says, so is it that most women that bleed after childbirth, the bleeding, is it due to the tears you mentioned? Because you were talking about tears. So the bleeding after childbirth, she wants to know if all of them or most of them are due to the tears.
There are several causes of bleeding in pregnancy, like I've mentioned. There are two groups of people. We have people in their first pregnancy. We have people who have had other deliveries in the past. So the commonest cause of bleeding in women who have had several deliveries in the past is postpartum hemorrhages, uterine atony. The uterus will just fail to contract. It could also have been that the placenta after birth, part of it, fragment of it may have been retained inside the womb, inside the uterus. That will also cause them to bleed. It's possible that the woman probably may have had some bleeding conditions that may have necessitated that bleeding, but the commonest cause in over 80% of cases is what we call uterine atony. The uterus will just fail to contract because of several factors. So the uterus fails to contract, and it's common among this group of people who have had several deliveries in the past. It's not so difficult to manage because there are two arms of the management. The first arm is try and see whether you can apply some medication like oxytocin to help the uterus to contract better, so that you can arrest the bleeding. The second thing is, if that is not possible, check whether there are genital tract injuries. There's a vaginal injury, there's a cervical injury. If those are not there and the uterus still remains flabby, it's not contracting, you may have no option other than to go to the theater to remove the womb. The womb is actually the uterus. That may just be your final bus stop. But
Sir, questions are
for
coming.
those in their first pregnancy, it's important that, in fact, if they don't suggest it to you, if you are carrying your first baby and you are in a hospital, you have finished, you have delivered successfully, but you continue to bleed, but the person who took your delivery keep reassuring you that the bleeding will stop and they haven't checked your genital tract, on your own, you can advise them, please come back, check whether there's any tear inside my body. Particularly those who are carrying their first pregnancy, it's very important. Genital tract injuries are common in women who are delivering for the first time, and it's important that that is checked after these women have delivered.
We have one comment, sir. It says, please, but one can take folic acid daily before conception and during
Of course,
pregnancy.
yes. Very well. In fact, it's recommended that every woman in the reproductive age group should take folic acid, particularly those who wants to get pregnant within the next 3 months, as in just before they eventually become pregnant. They are advised to take folic acid for a period of at least 3 months before they eventually become pregnant, because of the benefits of reducing the risk of neural tube defect and other neurological abnormalities that could complicate pregnancies. So it has been documented to be beneficial, and it's better to be started even before the pregnancy and continue through pregnancy.
Thank you. Final question tonight, sir. Final one. What fruits should a pregnant woman not eat? I'm asking this deliberately. I would have said, what food should she eat? But are there any fruits a pregnant woman should avoid during the course of her pregnancy?
I can't specifically say there are fruits that pregnant women should be avoiding. Women should eat, but you understand that there are certain food that increases the risk of heartburn, and things like that. Pregnant women are usually prone to having heartburn because of the effect of progesterone. Some of them may have been an ulcer patient even before the pregnancy, which will worsen in course of the pregnancy. We encourage women to take a lot of fruits. That's usually what we encourage them to. But very acidic fruit, we could worsen that effect, of heartburn in pregnancy, could then be avoided. But I can't say specifically some fruits, which should be avoided by this group of pregnant women. Most of the fruits that we have, most of them are safe, and they contain quite a couple of energy and some vitamins that can, be beneficial to the pregnancy.
I have heard, and this is with so much controversy, that a pregnant woman should avoid pineapple. Please, sir, what backing do we have with this conversation medically? Should a pregnant woman avoid pineapple? Does it have any negative effect on the woman or the baby? And then quickly, because I know we have taken your time, sir. In addition to this, what about cold water during pregnancy? We have heard pregnant woman, do not take cold water, it will affect your baby. The baby will come down with jaundice and the rest. Please help us.
This cold water is not contraindicated in pregnancy. If they feel the need to take water, whether warm or cold. They should take water and enjoy themselves. Please, they shouldn't suffocate pregnant women. They shouldn't. Pregnant women could do anything they want to do. Do you know that some women have even said pregnant women should not be eating snail?
Yes.
So there are many things you will hear from marketplaces and a couple of other things. Like I mentioned, those who have pregnant men could also have allergies to certain things. So outside that, if eating pineapple creates a lot of problem for a particular pregnant woman, it's fine. But I'm not sure there's any incontrovertible evidence to say that pineapple will cause certain harm, to a pregnant woman once it's taken. And like I've mentioned to you, things that were not good for you before pregnancy, also avoid them in pregnancy. Because they may worsen some of those conditions why the woman is still pregnant. So that's where I will leave it.
Thank you, sir. We have one of my follower just commenting right now. I have put to bed baby boy. I think I know this name.
Congratulations.
Yeah.
Congratulations,
Congratulations. Congrats.
Sazua.
So happy.
Congrats. Thank you.
Congratulations. Thank you so much, sir. I'm so grateful. Thank you for your time. I don't know
Thank
how
you.
much to thank you. You help us put this information out there. I'm so grateful. Even your very tight schedule, you are still at work and you have things to do, and here you are tonight. We don't take this for granted. Thank you very much, sir.
Thank you. Thank you. We'll see some other time.
Thank you very
Thank
much.
you. All right.
Ladies and gentlemen, thank you. I'm sorry we couldn't take your comments. The agreement was for 20 minutes, but here the time is 40 minutes today. I hope Dr. Joseph will be able to join us next week. He's really busy. If he can, he'll be here again to talk to us. Thank you once again. Help us share these videos to your friends, to your network. I beg. This, see, it's free. Nobody's paying anything, and the doctor is coming here free with a bond data. I beg. Share to your community. Those your group, those your village people group. Share the video to them. God bless you. Like I always say, good life now waiting. Good life. Nah, sense. Yeah. Thank you. Take care and have a wonderful night. Tomorrow I might be online again to discuss with you. Bye bye. Thank you. Thank you. Thank you. Osezua, congratulations. Congrats. He said, that video, that video on how to get boy, he worked for me. So all I'm going to tell you to do for me, Osezua, when did he put to bed? When you born? When you born? When you born? When did he put to bed? Congratulations, Congrats. I'm so happy for you. I have so many women on TikTok, on Facebook, tell me, I don't born, I don't born. Congratulations, I'm so happy for you. And anybody where they try to get belle, God will give you your own picking. You go carry your picking, you go celebrate. Anybody who don't laugh you, God go shame the person. No give up. No give up. Keep believing, keep praying, and you carry your picking. Congratulations, congrats. I'm happy for you. Help me share the videos to other people on Thursday. Oh, on Thursday. Congratulations. Extend my regards to your husband. Take care and have a wonderful night. Bye bye, everybody.